Okay, welcome. Um, Nice to see all of you on your little Zoom rectangles today. This morning we are hosting a JBI gLocal here at TUN, and you can see some of us are together in a conference room on campus, and then you all are lovely in your little Zoom rectangles. I'm Dr. Katie Chung. I'm the director of our Touro University Nevada JBI Center. The JBI Healthcare Research at Touro University Nevada is our entity name. And we are presenting this event to introduce you to JBI if you're not familiar, and to share some of our clinicians' experiences implementing evidence-based practice in primary care. If anybody has any trouble hearing me or tech issues, please shout out in the chat and we will do our best. And I never know if I should say that or promise that or not, but we'll try. So I'm going to share some slides with you. Let me get this shared. Go down. Presentation mode here. This is like the most stressful part of the day. All right. So, who is JBI and what the heck does that have to do with us at Touro, Nevada? JBI is a global research consortium, and their goals are to help us globally connect to get evidence-based care, the best evidence, to the bedside as quickly as possible. This is Professor Zoe Jordan. She is the executive director of JBI, and the mothership of JBI is at the University of Adelaide in Adelaide, Australia. This is how down and dirty how JBI works. So they lead this global collaboration with over 90 collaborating entities, including universities, healthcare organizations, hospitals, non-governmental organizations, and they provide evidence-based education software for helping us to do these research projects and then research through their journals and disseminations. They're across 40 countries, in partnerships with a lot of experts, and goal, bottom line, improving health outcomes. If you're not familiar with JBI yet, these are some of their taglines. So their vision is better evidence, better outcomes, brighter future. And then the mission is promoting and supporting evidence-based healthcare. And they use this symbol a lot of like a little pebble dropping in water, because the ripples of what we do and how we support patients just continue on and on. We don't always know where those ripples will end. JBI is focused on more than just healthcare effectiveness, but also how to get that most effective evidence actually implemented. So what are barriers to implementation? What were the struggles? What do the patients prefer? Sometimes we in healthcare forget the patient because we're so busy trying to do what we think is right, and we might not always remember the patient's preferences. And then what's the impact of context? And that's what you'll be hearing about today from our presenters, because the contexts that they are working in are medically underserved, which presents an even greater challenge to evidence-based healthcare. I actually love this slide. The research practice gap, if you haven't thought about it in this way before, research is advancing. And we know so many things in in writing and in thanks to different clinical trials and research studies, but getting that to the bedside, getting that to the patient is very complex, and there are just a lot of barriers and challenges there. I don't know about you, but I wouldn't try to jump that gap by myself. So we use a lot of things that help move that research forward into practice, dissemination, and JBI emphasizes starting small and then growing practices that are working and gathering that data, gathering that evidence and sharing that with one another so that we know what the situation is. Also, this is really commonly quoted, and I wish I could find the original citation for this, but the common quote is that it takes an average of 17 years to get research into practice. And I've actually read different numbers, anywhere from 2 years to 17 years, depending on the specific piece of evidence. And that's crazy. Like, that's a whole generation of patients and providers that are, not, that don't have the best evidence right at the bedside. So that's really difficult. Talking about implementation of evidence, JBI follows a process that's really very similar to the quality improvement process of Plan, Do, Study, Act. If you've heard of that, I know a lot of us have. But we identify the problem, the stakeholders, engage those change agents, assess that context. Context includes the environment, and those folks have to be ready to change. Review that practice against evidence-based criteria, try to implement a change, small and steady. Small changes over time really add up. We always go back and reassess and consider sustainability, and then just keep that cycle going. So even though this looks like a circle, you actually could envision this as a slinky. We do this over and over and over to try to get the best practice to the patient. And as I said before, JBI has over 90 collaborating entities, like we're right over here. And we're very proud to be part of that collaboration. JBI is actually the largest global collaboration to try to integrate evidence-based healthcare with a theory-informed model. And as an entity, we definitely promote and support the use of evidence-based healthcare here in our community and globally. And every entity leads initiatives in their own region and state. So that's what we're doing today. Dr. Meekum and I are like way back here somewhere. If you zoom in, you can see us. So that was at the mothership a couple of years ago. Well, what the heck is a gLocal? I just think it's a funny word, but it's more than that. A gLocal was actually popularized by Roland Robertson, who is a sociologist. And he emphasized that we take a global outlook, but we adapt it to local conditions, which makes perfect sense, right? Even if the best evidence states a certain thing to do, we always have to adapt to our environment, our patients, our context. So that is what the gLocal is all about. And working globally includes local knowledge advantage or disadvantage, and location-based advantage or disadvantage. Here we are in the desert Southwest, and we are medically underserved and we're educationally underserved in terms of the level of education in our population. Those are challenges to getting the best evidence to the patient and helping the patient understand how to use that best evidence. And so without further ado, though, if you would like to connect with JBI, please do. They're everywhere. I'm more than happy to share links moving forward, but I will turn it over to Dr. Kelly Meekum to talk about, no, we're gonna turn it over to Dr. Rebecca Edgeworth to talk. Is that okay?
Of course.
Okay, to talk about her program first, and let me get to the correct slides. And thank you all so much for being here with us today.
Like any meeting that's going ahead of schedule.
I know we try really hard.
I like that.
Oh, don't jinx it. Sorry.
Oh, it's okay. Was there a question?
No, I was just saying don't jinx it by saying that.
Jinx it, for sure. We do not want to jinx it. Okay. Here we go. And would you please introduce yourself, Dr.
Sure. Can
Edgeworth?
I advance my slides or do you want to?
Do you want to? I think
Would
you
it be
can.
easier? It's up to you.
Try it.
Okay. Okay. Good morning, everyone. I'm Dr. Rebecca Edgeworth, and I'm on the faculty here at Touro, and I work mainly with the PA department. I'm here with our coordinator, Anthony Smith, who, if I didn't have him, there's no way that I'd be able to do all the stuff that we do. I am from Las Vegas. My entire career has been about outreach and getting people access to care when they don't have access to care. So this is something I'm passionate about. Also, I'm very passionate about teaching the next generation. So just really quickly, and I've had a lot of coffee, so I'm going to talk fast. Feel free to ask questions, though. Community health is really important. Lots of evidence shows that people have less hospitalizations, less disability, less stress on the system if people can be healthier. We do outreach because obviously it helps the community. It does help the community quite a bit. These are populations that may have a Medicaid card, but just have no access, may be undocumented and don't have access to care. Lots of different ways that we're helping the community to be more well. We're also helping our university because Touro is known in the community as being a very big provider of medical care. That gets us more press, but it also gets us better students who apply. It gets us there's a lot of benefits, more grant money, things like that. And then, of course, it helps the students. And this isn't just students going out and handing out like soup. We're actually providing real live medical care. I'm an internist, so the medical care that we provide as much as possible is evidence-based. I'm going to really quickly go through some of the different models of care, but mobile health clinic used to be an RV. And now it's not. We haven't used an RV or a mobile unit for a few years during COVID. We changed our models around, and we do all different models depending on how we need to bring people to the table. There's a lot of evidence in the last few years. I think around COVID is when street medicine started to get popular. The idea of bringing medicine to the person instead of making them come into a clinic, and transportation and all of that. And street medicine has really taken off now that Medicaid started reimbursing for it, which was just maybe a couple of years ago that they started reimbursing. So people have street medicine teams now. And I will say that homelessness is very complex. There's a lot of different things to know about it. I would say one of the main things to know is that homelessness is not a homogeneous population. There are people who are one paycheck away and now they live in their car. Those people are a lot easier to fix. They're a lot more motivated to fix themselves. And then there's chronic homelessness, which is defined as over 6 months. Federal definition is over 6 months of homelessness, which could be in an encampment or a shelter or a car or a tent or on the street. It could be a lot of different things. So chronic homelessness is, if you go to SAMHSA, you'll see that it's associated with serious mental illness, SMI, often addiction issues, things like that are tied to chronic homelessness, incarcerations. It's a lot of other things that you have to deal with. Those are the ones that are the hardest to treat, because their medical care is never at the top of the list. I would say that. And then usually people don't have just one problem, just diabetes. They have all different things like we were talking about. So ideally you would be able to work with partners in the community, either at the event or have an easy referral system where you could send people. We see chronic medical conditions as an internist. I love these conditions. Diabetes, hypertension, that's my jam. That's what I love to do. And we don't just throw pills at people. We have long talks with the students about JNC guidelines and AACE guidelines for diabetes. And we care for people in an effective, appropriate way that's evidence-based. Sometimes it doesn't work out because of resources, because of patient preference. They told me I have high blood pressure, but I'm not taking no medicine. So even just educating people about what the risk factors are and when you need to go to the ED, sometimes is all we can do, but we try. Sometimes people have injuries, as you can imagine, living on the streets. Bed bugs is a lot more popular than lice, but it really bothers people. So we try to help them. It's especially bad in the summers. And then sometimes we have hospital discharges. Just last Friday, we were in a dirt lot at Catholic Worker, it's called, and a guy showed up and he still had his band on, and he also had a band that said fall risk. And he was in a dirt lot with no walker, so fall risk, I guess, is what he had. I guess that's what we get. So people who have just gotten out, they're still oozing from their IV that got pulled that morning, and that's what it is. So these are some of the common injuries that we see. I could move this, but nobody here is squeamish, hopefully. But oh, sorry. So some of the injuries we see are things that have never healed, like diabetic ulcers. This guy had a broken arm and it never healed. And this is what happens. People leave AMA. And then I have, in my whole career, I've seen one little baby frostbite toe, but I see an awful lot of this other picture is a giant eschar of when somebody falls asleep on the cement when it's 116 degrees out. So I see lots of back injuries, very hard to care for that. We see acute stuff, thermal injuries, things like that. Like I said, mental health issues. I mean, ideally, when we go out one time, we're not going to be able to really fix anybody's mental health. There are some pretty good resources in Las Vegas for people to be sent to on a walk-in basis. Substance use, sometimes people are ready for help, sometimes they're not. We go out with people who can connect them to care if they're really interested. But oftentimes we have to meet them where they are and what their readiness scale is and that kind of thing. Medical care is never, it's where I'm sleeping, where I'm gonna pee, where I'm gonna eat. Their medical care is all the way at the bottom. And then they're like, well, if I get sick, I'll just go to the ER. That's not good for them. It's not good for the system. It's not good for anybody. So that's what we're trying to prevent. Follow-up people, it's just not on their priority list. Sometimes all we can do is tell people, go to the hospital, or I think you're okay, but if you have this, then go to the hospital. Sometimes we're just giving them really good advice. We generally do screenings on everybody. Anybody experiencing homelessness, if they get checked out, gets a free 24-hour bus pass, which is a big incentive. Sometimes it's acute care, sometimes it's chronic care. Like I said, sometimes it's just really good advice. So I'm just going to very quickly go through some of the types of events that we do. Sometimes we go to screenings in Hendertucky, downtown Hendertucky. There is some very poor area right off of Water Street. There's a senior center where there's some people who are poor, but also a few people that are experiencing homelessness. And we screen them, get them blood pressure medicine, get them referred to wherever. Most commonly, they have Medicaid. So we tell them what the closest clinic is that they can go to and get really appropriate follow-up. There's also some self-standing clinics. You can see this was during COVID. Sorry, we got face screens on. But this one at the Shade Tree on the 3rd floor is a domestic violence shelter. They have trafficked women. They have women and children that have been victims of domestic violence. So these are sometimes colds, they're all piled on top of each other. So illness spreads pretty quickly. And it can be that they fled their abuser without their medication. So we try to get that back on top. It's often mental health issues too, as you can imagine. Shelters are maybe the worst for bed bugs. We go and set up at Catholic Charities, and they've done everything to get rid of bed bugs, but it's a big problem there. And people have chronic sores and things like that we try to fix up. And another one, there are some, I'm sorry you can't see all of this. Should I move this? I'm going to try to move it. Do you think it'll work?
the Zoom people can see it.
I know,
can't,
but I want
yeah.
us to see it. There's at least
You
as
can
many of
make- you
us.
can click
Okay,
that
great.
little-
So,
Right.
you can see here that this is what we did this isn't pictures from last Friday, but we were out at a dirt lot. It's next to a shower truck. And, I have to say that a lot of the success to us being able to do all of this outreach is this guy who up until right now is still our provost. And this is, Dr. Priest, who did a mission in, Chile. So he speaks Spanish. So he comes out with us. So it's only going to be successful if we get support from the top down. And Touro has thankfully always been very helpful with letting me do any dang thing, right? I just have to make sure that the students are safe, which of course I do. And the Giving Project is a monthly event. It's a huge event. 600 plus people come through there. It's one Saturday a month, and it's all kinds of things. I've had everything you can think of. I've seen there. I had a guy who was from Colombia who said he had la lepra. Do you guys speak Spanish? Anybody? Spanish? La lepra. It's leprosy. Leprosy. So you get to see that it's really invaluable for the students to be able to see all of these kind of things. And the second to last one, this is one where Amy DeFord goes out in a truck. We go out with Metro. We go out with Help of Southern Nevada. We go out with the city of Henderson, and we go out to tunnels and encampments. We don't go into tunnels. We go up to tunnels, and people come out to access care, and we do the best we can to give them the best medical care they can. This is the last one I wanted to mention. It's an event that we do every year. I'm the medical dental director, but it's a very big event. I'm not in charge of the whole event. But this is the best place to access people is when there's already huge organized event. And you're like, oh, that's so great that you help so many people. It's always right before Thanksgiving. But honestly, what we really do is get them follow-up, right? Because we're here today, but we're not going to be here tomorrow. And how do they get follow-up? How do we check their blood pressure? How do we see how they're doing with their treatment? Really, we try to get them. So we have different MCOs come, the Medicaid providers come and let them know, hey, you're going to follow up at this time, which sometimes is a mobile clinic. Sometimes they have mobile clinics and they can set up appointments for that. And that's it. So this is how to reach me. If you ever have any questions about if you wanted to start your own thing, or if you want information about what we do, that's Anthony and I's contact information. Does anybody have any questions?
I was going to ask you about follow-up because that seems to be a concern when people set up programs on the administrative side.
Absolutely.
Yes.
So it's always about follow-up. So you're really missing the boat if you show up and just take care of the one thing. And it's never one thing either. So the shade tree is a good example. The shade tree might have somebody who's pregnant. I'm an internist. Ew. That is not, ew, I don't do that. Like, I can keep people alive, but I'm not an OBGYN, right? So the key is talking to the case managers and saying, hey, Miss Smith really needs to be connected, and they have a van and they'll help them make an appointment. That's the ideal situation. When we're at the Giving Project in the courtyard we usually see somewhere between 30 and 50 people. When they have chronic conditions, as they surely do, if it's HIV, there's a few clinics in town that specialize in that. But if it's just regular primary care, then on the corner, just a block away on the corner of Main Street and Four Master is a Nevada Health Center. Is it ideal? No, but it's right there. And that's where we usually tell people, hey, we'll give you 30 days of this for now, but I need you to go up there and get checked out, right?
Yes.
Yeah, follow-up's key.
And I also noticed that you mentioned several times, many of these folks have Medicaid cards.
100%.
And as we know, as healthcare professionals, someone may have had a Medicaid card, which technically is insurance coverage, and yet they cannot access the care. Huge problem, something that our policymakers definitely need to understand better.
I would say that there's a lot of reasons why a lot of people have a Medicaid card because they've gotten into the system through a hospitalization or something, but they just choose not to utilize it. When you're in these kind of straits, you just live with what you have. Also, in order to get a Medicaid card, you need a mailing address. So it comes pretty quickly, but the courtyard, a few places, there's a place called the Care Complex that'll have a mailbox where people will be able to get their card. Also, people show show up in Vegas and they just haven't gotten into the system.
Mhm.
And so we can, at the Giving Project, for example, the welfare office, which leads the healthcare navigation for the state, we can send them right there and just say, hey, go ahead and sign up, and they'll help them get signed up. But yeah, it's not just one reason why people don't use
Yeah.
Medicaid. I wish it was easily fixable.
Have you noticed any changes with federal administration with any of the budgetary things going on or not yet?
Well, federal does drive Medicare.
Mhm.
And so I haven't seen changes there.
Mhm.
There's rumors that Medicaid is going to be affected,
Mhm.
but I will tell you that Trump has said he doesn't want Medicaid affected for people who need it. Lombardo, our governor, has said he doesn't want, and the legislators, all of the legislators, there is nobody who is trying to go after decreasing benefits to these people because it would be very short-sighted. Without care, they would end up in the emergency room and they'd be part of the emergency Medicaid system.
Yes.
So I haven't heard of any people who genuinely need Medicaid having their Medicaid threatened.
Rumor is a very good word to use.
Well, there are
you know,
there's all
yeah.
kinds of rumors, and I don't think it's ridiculous for us to have the conversation, even though it's scary to people to talk about it. I think that you have to be, in medical, you have to be ready for anything. If this goes bad, what do we do if that happens? Where will we send them? So I think being prepared is fine, but I will say, I haven't heard one thing about anybody genuinely wanting to take away Medicaid from people who need it.
I would hope not.
I would hope not, right?
Yeah. Thank you so
Sure.
much.
Well, this is my email address, so feel free to
Okay.
reach out if you have any other questions.
Absolutely. Thank you.
Were we able to see if there was questions on the chat?
Oh, sure. I can check it out.
Oh, I don't know how to do that.
I can
I
check
also
it out.
have been monitoring the
Oh,
chat.
oh,
Oh,
you
you
have
have been, okay.
Is there anybody who chatted a question?
Just if we were recording, and we are, so we should be good there.
Hopefully that was close to 10 minutes.
That was excellent.
Actually, I
Thank you
had a
very
quick
much.
question.
Yeah.
Do you usually get any aggregate data? Like, do you collect any
I
aggregate?
love that you're asking that because data really tells the story. Data
Okay.
tells the story to the university. They want to know what we're spending all this time on. Data, we can report to grants that we get. They want to know that kind of thing.
Mhm.
We use Qualtrics
Okay.
and we collect data. It is de-identified data. So it has the patient's age, not their date of birth.
Okay.
It has their race, ethnicity, gender, including non-binary.
Mhm.
It includes, if we've provided them with acute, chronic, or screening only. It's if they're in their own home and poor. We do other outreach for like LGBTQ. We do some outreach for low income immigrants. That's the clinic I'm going to today. So we collect that data too. If they're in their own home, sheltered or unsheltered. What am I missing? Oh, if we provided them with an incentive, which is only for people experiencing homelessness,
Veteran status.
veteran status. Oh, if you speak English or Spanish, just as a data collection. We also collect if they have insurance or don't have insurance. We take care of a lot of people that for a variety of reasons don't have insurance.
And I guess like my final question is because, students want research and I'm the data scientist, are we allowed to access that data?
We have accessed it many times. As you might know, the PA department requires a master's level project,
Right.
which is at least a poster, but sometimes published.
Yeah.
We are an academic institution, so of course,
Mhm.
and we've had, it's not just me, I usually have 2 projects that access the data, per year, and then other faculty have other projects with their students, doing ultrasounds or collecting data or all different kinds of things. Yeah, we absolutely use that data.
Okay.
Mhm. Because it's
Yeah.
it doesn't even have to be, I think, in aggregate. I think it passes the test for not taking advantage of anyone because it's completely de-identified.
I have a question. So how are you collecting the data? So are they filling it out? Or are you guys filling it on their behalf?
That's a great question. Our students go out in the community. They go to Volunteers in Medicine, which is the clinic that I'm going to this afternoon. And if it's a clinic that is not a big group thing, then we have them enter it in. They have to enter that data into exact anyway as like a patient log, so they're used to entering that in anyway, not too hard. When it's a large scale event, like any of these group events, they fill out their progress note to put in the EMR, and then we collect the data on a sign-in sheet. And then who has been helping us?
Like Oasis.
Some really nice people in Oasis wanted to participate on a voluntary basis, and they've been helping us enter the data in. If we have the students enter it in for the big events, it won't be as accurate as Oasis. I'm sorry.
Sorry, I
to
have
say.
one more, I have another question.
No, as
Okay.
many as you like,
Yeah, so, not, cause
unless we're out of time and
Yeah.
then, okay.
You're good.
I feel like I knew a lot about what the PA program was doing like prior to COVID, and then it sounds like, you guys kind of had to like you're not doing the actual mobile,
We're not.
clinic anymore. How often are you going out, and then roughly like how many patients are you guys seeing like on an annual or academic year basis?
Oh, that's such a great question. So my we just applied for a grant, so I figured this out. People experiencing homelessness only is around 150 people per month.
Okay.
Times 12. We see quite a few more people with our other populations, which is well, DV is usually a shelter, so that's included in homelessness, but LGBTQ and low-income immigrants, which is a Mexican consulate, things like that. And then substance use, if we take all of that, what do you think? It's another 100 per month in all those clinics? We send the kids to a methadone clinic too.
Roughly, maybe a little bit more, depending.
Yeah, I would think that would be kind of a minimum.
Okay. Awesome.
Yeah. If anybody has any other questions, please reach out. I'd be happy to help you. I would love for the whole university to do more of this.
Yeah.
When we ask the students, why did you pick Touro? A lot of them say because of all the outreach you do. And then some departments have a lack of ability to do this.
Mhm.
But it's not because the students don't love it, because I think
Yeah.
the students would love it.
Yes.
So let me know if there's anything I can do to expand what we're doing.
Awesome.
Yeah.
Thank you.
No shortage of patience.
Thank you so much. Keys. Can you grab her keys from the?
Oh, yes,
Yeah.
yes, I'm sorry.
Okay,
Yes, I know
give
what
us
you're
a
talking
second
about.
to
Oh my God, I
transition.
guess I would have noticed that. Get in my office.
Yes. Give me a second to transition PowerPoints here. Thank you so much, Dr. Edgeworth.
Of course.
One thing up.
Thank you.
And
I'm glad you remembered that.
absolutely. And Dr. Meekum, I would like for you to introduce yourself.
Okay. So I'm Kelly Meekum. I am one of the faculty in the nursing department. I'm actually the deputy director for our JBI group as well. We are currently actually doing a workshop on training for teaching students how to do comprehensive systematic reviews, which is pretty exciting. We always have a really good workshop each year for students to learn how to do systematic reviews and enhance the amount of evidence that's out there as it relates to healthcare. So the other arm, yeah, I guess I can take this here. The other arm that JBI does is they do have an implementation program training. Dr. Chung and myself have taken the implementation training. We've gone to Mississippi and learned about it, and then became trainers, and we still participate with Mississippi in doing some of their trainings. So I'm going to talk about a project that was, we did it through they have a program software that is supposed to like help facilitate getting evidence into practice. So in the US, we call that quality improvement. They call it best practice. So what we focused on was the clinic at Touro. And we wanted to implement a vaccine reminder system for our primary care clinic there. So I just want to point out too, we also had a couple of our DO students that helped. And I can't see the names, but they were also fabulous in helping us do this project. So, all right. So I'm going to move forward. So I'm going to just kind of go over some benefits of vaccination because we're eventually going to write this up. And these are compelling statistics when you look at the benefits of vaccination. And there's estimates that since 1974, 154 million deaths have been prevented globally. The World Health Organization estimates that 2 to 3 million deaths are prevented annually through vaccination. So it's incredibly important. There was some mathematical analysis or statistics that were done, predictions that were done that looked at the benefits of COVID-19 vaccine when it came out. So that analysis showed that in the first year, the vaccines, that there was anywhere, and it kind of depended on how they actually did that mathematical analysis, anywhere between 14 to 19 million cases that were prevented globally, and that led to about a 63% reduction in total deaths globally, which is very significant. And then, of course, we know that vaccines are important because they help prevent hospitalizations and long-term disability. They help decrease healthcare costs, and they improve population productivity. So some of the challenges that we're facing with when it comes to talking to patients about vaccination, of course, is now social media and misinformation, which has led to a huge lack of accurate information and knowledge about vaccinations. And then patients also have a lot of fears about possible reactions or side effects, or if it's appropriate. In our primary care clinic, we also have specialists that are rheumatologists, and they have patients that are on biologics. Some of these patients, they have to be very careful with certain vaccines, like if it's an attenuated type of vaccine, they may not be a candidate to have those type of vaccines. So it's just important that patients get this type of information. Of course, we have always had a religious-based hesitancy that has been since we started vaccinations as a population health movement. Of course, and we see this, and probably Dr. Edgeworth sees this, is some of it is if patients are uninsured, vaccines can be fairly expensive. And I was just doing a little research just to even look up like the cost of getting the flu vaccine. If you don't have coverage, it can range anywhere, depending on where you're getting it, anywhere from $400 to $110 for a patient if they did not have coverage. COVID, if they don't have coverage, and now that's it's not always used to be that was provided for free. But now that's not necessarily the case. That can range anywhere from $90 to $200 and something for patients. And then we still have healthcare professionals that are not recommending vaccines. And I'm going to just tell a little story here because it's been very recent. My husband is very involved in getting advocacy for healthcare, getting healthcare individuals into our government systems so that we have a say. He was recently interviewing a physician in Las Vegas who wants to run for Congress. And it was interesting that his take on the COVID vaccine, he felt like it should be not recommended in the state of Nevada. He had a stronger view about it, but it's just interesting that you still, even with healthcare professionals, have this huge differences in views about vaccination and that relates to the misinformation. So, oops. All right. In primary care setting, why it's so important to try to do vaccination within primary care setting is Medicare and Medicaid point out when they look at their records that still 46% of vaccines are administered by primary care in those settings by those type of providers. And that's still, I was thinking that the retail pharmacies would actually be providing more vaccines at this point, because I feel like since COVID and some of the special needs of like administering COVID, that might have changed, but their numbers are in the 25, 30%. So still most patients are getting their vaccines through primary care. And then there's other factors that from primary care that are important when it comes to vaccination. And that's because there's very accurate information. Usually we have good records on our patients. We know our patients. We know what might be recommended, what might be problematic for a patient. We hopefully have more complete records because of the patient records. Most primary care have some accessibility depending on the population that you see to the vaccines, and they can be given right there. It makes it's more convenient for patients. There's access to healthcare providers and staff, so they can ask questions and get their information accurately. And then we have many now that most primary healthcare settings have some type of EHR, where we have some centralization of knowledge and data on our patients.
That's electronic health record for non-healthcare.
Yeah, sorry. Yeah. Sometimes I can talk about it. So this is actually comes from JBI itself. They have evidence summaries that they will actually use that you can bring in and use for evidence implementation projects. So they will do a type of systematic review. They do rapid reviews to gather this information, and they are continually updating that information. And then they will rate the quality of that information. So these were the recommendations for setting up a vaccine reminder system. They were saying it's recommended that patient reminders and recall systems should be implemented to improve immunization coverage levels in primary care. Okay, that different types of reminder and recall systems should be tailored to suit specific provider and practice needs. Some of these just make complete sense. That telephone reminders and letters actually are preferred. They tend to get better responses from patients when they look at the best evidence. But they also state that you should consider tailoring it or integrating it with like a billing system. So sending out reminders in that fashion as well. So, so as far as Touro Health Center, what type of primary care setting we have there, it is a not-for-profit. And we do serve patients of Southern Nevada. We see a lot of Medicaid and Medicare patients. And we have patients that are not insured that come to our clinic as well. The services that are provided there, of course, we have our primary care providers. We have physicians who do the osteopathic manipulation treatments there. We have gerontologists and we have rheumatologists. And we have, of course, then PAs that work there that see patients, and then I was there as the nurse practitioner. The goal of the clinic was to provide patients with compassionate, quality, and culturally appropriate care with an emphasis on shared decision-making and education. And of course, we use that as educating our students here as well. The clinical staff that is there, we have medical assistants, we have front office receptionists, office managers, primary care providers, all of our providers, and all of those, when you look at implementing a project like this, you want to get feedback from all of them. They are the stakeholders. And then for us in trying to do this project, the one thing that we wanted to use was our patient portal, which was through our medical documentation system, our EHR. All right, so the objectives was that we wanted to implement a reminder process. We had not done that yet. We didn't have an official process for a vaccine reminder system at the health center. So we first needed to determine compliance with the vaccine reminder system, what was there, what have we done in the past, what barriers and facilitators we had for a vaccine reminder system. Then we had to set up the process, and then after doing that and implementing, we wanted to evaluate the outcomes from that. So, and Dr. Chung talked about this a little bit. This is the framework that JBI uses and the framework for which we used as well for our project. And so what they do is you'll have an initial audit. So we'll look at and, do chart evaluation or talk to the stakeholders and evaluate what's currently being done. So we did receive authorization to do this project. The current reminder immunization process that was there, really, it was just on more of a patient by patient if they came into the office. And hopefully they came in during the fall. That was when we had the biggest, reminder, we just think about it more, I think, as providers at that time. We also then wanted to make sure we designed something that was manageable, specific for the staff. We had critical shortages for staff at the clinic. And so the one thing we really wanted to be mindful about was not creating something that was going to overwhelm the staff because they were already working so hard there. So we made sure we got input from staff and from the manager. And we did review our audit criteria. And the two audit criteria were the vaccination reminder and recall system is implemented to improve immunizations rates. Well, that was no. We didn't have an official process for that. And the second audit criteria was vaccination reminder and recall system are tailored to meet the needs of the provider in practice. And the way we looked at it, we said no at this point, or at that point in time when we were doing that audit. So we also did a very small chart audit of our patients just to see how well we were documenting what type of vaccinations our patients were getting. And so what it showed was that in the chart audit, and I think it was a small population of charts. It was like 25, I think, charts that we did. So there only 75% or around 76% had their immunizations in the chart themselves that was updated. And that meant 24% we had some work to do. And then you could see the types of vaccines that were charted. COVID was the one that we had charted the most. And that had to do with what was going on during the pandemic. And there was a period of time where patients could only come in and be seen if they were vaccinated. Otherwise, they had to have a telehealth appointment. So it had a huge influence on what we were putting into the patient chart. So then phase 2, we were actually doing, designing and implementing that project. So we did meet with the staff and we came up with that we would do a reminder of an email sent through the patient portal system. And the email is on the other side over there of the example that what we sent out. We sent it through the patient portal because we knew we could hit a mass number of patients. There wasn't cost as far as mailing. We didn't have to take staff to fold letters and do things like that. So it was much easier process. And that was sent out in the fall in 2024. We had wanted to send it early in the fall, but because of staffing, we had to delay that email. And you could see it was sent out September 30th. The more ideal would have been to send it a little sooner. And it was sent to over 1,000 patients in the clinic. All right. And the other thing that JBI does is that we have to consider what the barriers are when you're implementing a project. And so they do GRIP, which is getting research into practice, and that you're looking at your barriers, your strategy, resources, and outcomes. So, and I might have talked about some of the barriers that we experience. So one of them is we don't necessarily have an IT specialist for our EHR, we use Allscripts. They are offsite, and anytime we needed an IT specialist, the person that is communicated through was either IT, and they will come over to the clinic and help us that way as a mediator for IT, or it goes through the manager, who is Lisa Coombs. So it's not the ideal situation. So a provider like myself can't just talk to IT necessarily with Allscripts. They may come over and do education for us, but that's just not available. So we had to make sure that we had that communication set up to do this project. I talked about the critical shortages of the staff. So for example, for the longest time, we've only had 2 full-time medical assistants, and we had 6+ providers seeing patients. We're not all there at one time, but it could be a huge burden for our back office. For front office, we also had critical shortages. So for people who are answering calls and checking patients out, the one thing we wanted to do was make sure that information for a patient portal system, that patient's information was updated and patient had access to the portal. So we were educating the front office, as patients check out, could you check to see if they have access? But at times they may not be able to do that because they're going to have to prioritize checking patients out if they just did not have the staff. And then vaccine availability. So that is like what vaccines we have there. You know, when do we need to refer patients out to a retail pharmacy to get things done? So those were what we saw as some of our barriers and how we needed to focus on those. So we sent out the email, and then afterwards, this is that same audit criteria. You're supposed to re-audit. And we set up a system, reminder system, and it was tailored for the clinic, essentially. All right, so the post-audit, we also looked at charts, those same charts, and looked at what might have happened afterwards. So the post-chart audit was done on November 18th, and I just as a reminder, we sent out the email September 30th, and at that point, we had only 2 of 25 patients that had updated their vaccinations, which was 8%. It would have been nice if we maybe could have pushed that out a little more, but there was reasons why we couldn't do that. So, so we implemented our reminder system. It was used through our EHR, our patient portal system, so which was good. So, in conclusion, we were able to create a reminder system. We were able to use the patient portal system and communicate with a large number of patients, which was beneficial. The downside was that there are patients that are not connected to the patient portal. There's some people who absolutely don't want to have to deal with things like that. So that did not hit all patients for the clinic. Though there was a delay, and that had to do with just staffing. We wanted to make sure that we sent that out when we had both our MAs and front office staff there at the clinic. So we wanted to time it correctly. The other I thought was like may have been a barrier was that really in the clinic, we did not have a full-time provider, and all of the providers that were there were part-time providers. So we also had wait time. So if patients wanted to call and come in and talk to their provider about vaccinations or things like that, there was some wait, and that may have been detrimental. Like patients may have been like, okay, I just don't want to have to deal with it. So they didn't necessarily schedule to come in to see a provider. This was kind of anecdotal. The staff did say that they had an uptick in patients calling about that. And then, as I think everybody in the room here understands, but there has been there was a critical change to our Touro clinic here on campus with decreasing services. And it's just an unfortunate problem with the current healthcare environment that we deal with here in Southern Nevada, where they they reduced primary care. So they eliminated primary care services. They eliminated the gerontology and rheumatology services that were there. So it's more focused now on just the osteopathic manipulation treatment. So even though we implemented our vaccine reminder process, the change in the clinic
Makes it unsustainable.
yes, was not sustainable. Yeah. All right. So any questions? Yes.
Sorry, did Laura Yavitz have a question?
No, I was just gonna go up to chat and see if there are any questions in chat.
I have 2 very quick questions. Did the EHR connect with WebIZ? That's the Nevada State vaccine information.
That is such a good question. I wish it did. No, we had to go into WebIZ and input that information.
Just, it's really commonplace nowadays, even in the cheapest, crappiest EMRs, for them to be able to connect with. We have the cheapest EMR at BMSN, and it's able to connect. They really want to connect that. Of course, if they had shots in California. No,
Yeah.
but I mean, if it was in Nevada, that would be good. The other question is, did you consider doing a standing orders for MAs or nurses to give vaccines without the provider? Since there's a lack of providers, maybe the staff could give vaccines if within certain parameters.
We have that for flu,
Okay,
influenza vaccine.
Good.
They do not necessarily, because we have pneumococcal, we have tetanus, diphtheria that was in the clinic. And those I think are the main ones. We probably have some other ones. So yeah, shingles, we actually will refer them to retail pharmacy, and that has to do with some of the reimbursement forms that they've had with it. So, yeah, but we do only for specific ones, which you're right, that being broader, where you could have something like that for the other vaccines would have been better.
Sometimes you do need a practitioner, but oftentimes it's pretty straightforward.
Yes.
Patient over 50,
Yes.
like that. Okay, thank you.
Thank you. Kelly, do you want to see if there's any chats? Just go. Oh, you want me to do it?
I won't mess anything up.
She was monitoring the chat?
Yeah, there's some, you'll see,
Okay.
some compliments, but no questions.
Okay. Yeah.
Well, I didn't get compliments, so good job.
You did.
You did.
You did.
I did. You
I-
got it.
Okay, I have to use my imagination, that's okay.
There we go. So you can
Fantastic,
show your
amazing.
work. Your work, it was fantastic.
Thank you.
The work that the PA
everyone.
department does isn't.
Okay, give me a moment here to switch over. Okay, so, would you please introduce yourself?
Yes.
Dr. Carter?
Yes. Okay, hi, I'm Dr. Kimberly Carter. I am assistant professor at the School of Nursing, relatively new. I just completed my DNP at Vanderbilt this past May. So I'm going to talk about the project that I implemented for my DNP project.
So is this, do you guys see this big or do I have to click it?
You have to click it.
Okay.
I was like,
Thank
I'm
you,
not sure what
Shirley.
they can see.
Okay.
Okay,
Thank
all
you.
right, perfect. Okay, so I did a project that was looking at sustainability and replicability of a medical fitness model in obese patients with type 2 diabetes. And the reason I chose this is because navigating safe exercise in people with obesity and type 2 diabetes is challenging for healthcare providers because there's so much just limited, structured, easy to use exercise resources. So I worked with a company called MyFitScript, and what they do is they create prescription exercises for various chronic diseases. So they have a lot of resources, a lot of just patient information and healthcare provider information. And so they come in and they train healthcare providers on how to effectively implement the exercise prescription in their patients, depending upon, you know, what disease process they're treating. So studies show that about 2.3 million of people in the United States have diabetes, with the majority of them being type 2. And it's been linked obviously to obesity. And so with the lack of structured exercise resources, we worked together and we implemented this project in a underserved primary healthcare practice. So what we did was we went in and we had the staff there, the nurses, screen patients with type 2 diabetes and obesity and just ask them if they were even interested in doing this project. And so we got about 5 patients total who said that they were interested. And so we started with collecting some baseline data when we did that. And we also gave them it's called an exercise readiness assessment tool. So it basically looked at like, are you ready to exercise? What are your risk factors? What is your readiness stage to move? Like, are you moving right now? Are you doing any exercise? Are you doing nothing? Are you doing like 20 minutes a day, or just kind of like those initial questions? And then we provided the practice with the actual exercise prescription, as well as the patient toolkit, so that they could give patients resources for engagement and accountability. And then let me see where we are. Let's have you go. Yes, yeah,
Okay.
yeah, you can, let me see, I think I went through some of that. Yeah, right there is perfect. Okay. And so as we collected baseline data, what we looked at was demographics, current weight, BMI, blood pressure, hemoglobin A1C, and then like I was saying, the readiness to move and the frequency of exercise. And then once we collected that, they were provided the actual exercise prescription and the resources. This was unsupervised exercise, so they were doing this on their own, but with their resources. And then we did follow-ups at 30 days, 60 days, and 90 days. And the same data was collected at those times. So I think I'm gonna have you
Go over.
Yeah, maybe because I'm gonna talk about the results, but then there's the table. I don't know if they can see it because it's little, it's small, but I'm not sure. Well, okay. I'm gonna keep.
Okay.
Okay.
Yep.
All right. So, we had 5 patients labeled as A through E. However, our patient B stopped responding, to calls at 30 days. So we were unable to collect data for them, after that initial baseline data. But this table you'll see there displays like their baseline weight, 30-day weight, 60-day weight, 90-day weight, total pounds loss, what the change in the BMI was, change in hemoglobin A1C, and also their systolic and diastolic blood pressure. And what we found was that the average amount of weight loss was among the 4 participants after 90 days was 9.5 pounds. We also saw a reduction in the hemoglobin A1C of about 1.1%. And blood pressure was a little bit more variable. So we actually saw an increase in the blood pressure. But when we look at, I'm gonna have you go down to right there. Perfect. Figure 1. Okay. Figure 1, so this one shows us the behavioral changes in exercise frequency from baseline to 90 days. Patient A remained consistent in their aerobic exercise from baseline to 90 days with on average a 150 to 200 minutes weekly. And they also remained consistent with their strength training exercise, which was, where is it? Sorry, I have to look at it because I've forgotten. It's been a minute. Aerobic strength training. Oh yeah, that's right. This one, they were not doing any strength training at all. And they didn't they didn't do any strength training throughout the implementation. Okay, patient C and D went from not participating in any aerobic exercise at baseline to routinely participating at 60 minutes weekly. And then patient C with their strength training exercise at 45 minutes baseline, they went up to, I'm sorry.
That's okay. Looks like they maintained.
Yeah, there they go. They maintained. That's right. They maintained their exercise. And then patient D went from no strength training to 60 minutes weekly. Patient E decreased their weekly aerobic exercise and strength training. And I'll talk about why that happened. Barriers. So that goes into barriers. So, what were the barriers to exercising? So patient A's barriers were that they had long work hours, and then they also suffered an arm injury at work, so that was hard for them to strength train. Patient C preferred to do water aerobic exercise. This was primarily implemented during the cold months. So because the weather was cold, they were doing this outside. It's just what they had access to. They stopped doing that during the cold months. But they did decide to walk. So instead of doing the swimming, they were walking instead. Patient D stated that they traveled often for work, so that made it more challenging for them to exercise. And then patient E, so the barriers with that patient was during that last 30 days, that he started a weight loss medication. It made him feel really bad. So he stopped exercising altogether during that 4-week period. All right, so then we're gonna look at next our readiness to change. So it's in the left
lower.
yes.
Got it.
The trans-theoretical model readiness to change. So this is kind of where we looked at their readiness to work out when we looked at the baseline to exercise and then going through the program. Patient A, so transitioned from the action stage to the maintenance stage. And then patient C and D transitioned from preparation stage to action stage. And then patient E, of course, regressed just because they stopped moving. So in the discussion portion of this, what we found is that overall, this prescription exercise program does demonstrate a positive impact on health outcomes and behaviors in patients with diabetes and obesity. We noticed that there were several physical health improvements with the average weight loss of the 9.5 pounds, the reduction in hemoglobin A1C, And we see overall that the patients did increase their readiness to move, and their ability to move, as they incorporated their aerobic exercise and their, strength training. Let's see. Let me go over.
Can I ask a question?
Yes, of course.
What kinds of, like, when you're saying exercise prescription, what does that actually look like?
So they are given specific like exercises, so specific strength training exercise. It's like a packet and it had like I don't know, at least 15 to 20 different type of like strength training exercises that they could do. Didn't require them to have a gym membership. So mostly like calisthenic type things. And then the recommendation of aerobic exercise of 20 to 30 minutes, at least 3 times a week was the goal.
Was that individualized to the patients or did they all get the same?
So they did all get the same recommendations because it was unsupervised.
Okay,
We let them choose as far as like what do they have access to
Mhm.
and what can they do? Because like the woman who wanted to swim, you know, she was like, I
Mhm.
can't run, I can't do certain things, so I want to swim or I can walk. So we let them pick that part. Just because we felt like it would be more successful instead of versus us trying to say, you have to do this. Yeah. Okay, sorry.
no,
Did I
go
answer your
ahead.
question? Okay,
Yeah.
all right. All right, so I guess I want to talk about now like the limitations that we had because there were some limitations. So this was implemented so in like I said, a rural area in East Tennessee during the time that this happened. Hurricane Helene was going on. And so that is what we believe has led to.
That's a little tricky.
Yeah. And that's what we found out about the patient that dropped out, like just the disaster related effects of like them being displaced from their home and trying to find like, you know, get all of that situated. That caused us to have dropout there. One of the other things that we had issues with was there was limited provider receptivity of this because we were supposed to implement actually in 3 different clinics. And the other 2 clinics, after finding out more about it, declined because of reimbursement issues. Just the lack of reimbursement and lack of payment, they didn't want to make this a priority or even attempt to implement. And then the other thing that was a limitation for us is we attempted to give them all, we did give them all pedometers. I'm sorry, lost my train of thought. We gave them pedometers. We asked them to wear the pedometers just as a daily thing, just to keep track of daily steps. And nobody wore the pedometer. Either they forgot or one lost it or they just like nobody wore them. So yeah, those were the limitations that we did experience with this. But overall, you know, it was the implications for practice. You know, exercise obviously is needed to manage diabetes and obesity. And what we found is if we give providers a structured like plan to implement it, if they have something, because it's not something that you really are taught per se when you're in medical school or nurse practitioner school or PA school, whichever school, to give them those materials to be able to really guide their patients on how to exercise and answer those questions when patients come in with, how do I do this? What do you recommend for this type of exercise? You know, being able to do that makes a big difference in outcomes for diabetes and obesity, as reflected by weight loss and decrease in hemoglobin A1C. So,
Dr. Johnson Glover, did you have a question?
oh,
Yes, I did. I did. So I'm wondering, because just because I talk about this a lot, is when they did the pre-assessment on these 5 patients, did they do an assessment on their social determinants of health just to ensure that there weren't barriers that would prevent them from exercising?
no, that was not a part of the implementation, which would have been good to find out. I mean, in the exercise readiness assessment tool, they were asked if they had any barriers, but there wasn't a specific assessment of their social determinants of health.
Okay,
Yeah.
okay. I was just curious. But great presentation, and I'm glad it worked out. Oh, the other question was, patient, the last patient, patient E, you said that patient went on a medication to help with the weight loss. Do you think what contributed more to the substantial weight loss? Was it the drugs or was it the exercise?
That I don't know,
Yeah.
honestly.
Yeah, I'm sure that's
almost-
hard to tell,
I can
but
only assume, right, because I don't know for sure, but because they didn't even exercise the last 4 weeks because they felt so bad, I almost feel like it was more of the medication than it was.
GLP-1.
Yeah, exactly. They wouldn't tell me what that wasn't disclosed to me, but
Yeah.
that's what I assumed it was. Yeah.
I had a question just about the sample, a little bit kind of like Tracy was asking. I'm just curious, like, were these insulin dependent diabetics? Do we know, like, if they, like, their severity of disease is kind of what I'm saying? Or do we know, like, were they already on GLPs already? Because a lot of insurance companies now are covering it, you know, I'm just curious.
Correct. So I was not able to be provided with that information, unfortunately. I wanted to be, but I was not. So I don't know specifically like what medications they were taking. I do know that they were not insulin dependent though.
You had access to their A1Cs though, right?
Yes, that was provided to me.
I find
Yeah.
this D very interesting. It actually gained 2 pounds, but changing hemoglobin
Yeah.
A1C that's a big change.
Mhm.
Yeah.
Mhm.
I gotta see what they did. Okay, oh, they started strength training
Mhm.
and, oh, they started exercising, basically.
Yeah.
Okay, interesting.
So.
Awesome, yes, agree, awesome. The reimbursement thing hurts my heart.
Yeah.
It's because we don't pay for prevention.
Mhm.
And how else are
It was a
people gonna
struggle
get this,
to
get
get-
this information?
Yeah.
You know, you
Okay.
have to be self-motivated and look it up yourself. If you don't know what a difference exercise can make to your physiology, why would you look at this? You know, why would you look for a certain fitness plan? You probably think that it has a lot more to do with what you eat or, you know, whatever.
And not wanting, yeah, because you have to take the time. It takes
Mhm.
time to go over these plans with patients and to implement it. And that's money.
Mm-hmm.
So,
It's interesting because Katie knows this, but at the clinic I'm at, we just opened in like January of 24. They implemented a health coach like for the clinic. Now, I don't know how profitable it's going to be in the long run, but patients have access once a month to this health coach essentially. So, and they get into a lot more of the weeds about diet and exercise because we do not have the time.
Right.
We really don't.
Yeah.
So I'm interested to see how sustainable it's gonna be at the clinic I'm at.
Mm-hmm.
And then it's surprising to me actually how many people have access to it and don't use it.
Mm-hmm.
Yes.
You know, because it also requires time to
Yes.
talk to somebody and do that. So I don't know, very interesting. I'd like to see it incorporated and maybe have better reimbursement for it in ways so we can
Mhm.
actually have like preventative, you know.
Yes, I think a lot of times the whole coaching thing is confusing to patients because it's unregulated, right? So you could have taken like a weekend class or you could be like
Right.
a total pro. It's, you know, you don't know.
It is a little unregulated. Yeah, the
Mhm.
people we have doing it are like basically personal trainers who have they were college athletes. We have a male and a female. And they both were college athletes. And so, but that's like all they do. So they've kind of got pulled into that space, but they're not registered dietitian. They're not, you know, so they have knowledge, but there's no like specific certification that qualifies them to be reimbursed, you know, I mean, other than maybe a personal trainer or whatever. So that's tough.
One of the
Yeah.
things that Katie and I actually thought about doing at the clinic at one point was implementing a chronic care program which tends to be more holistic, but you could fold like exercise and nutrition into it.
Mhm.
And that is something that Medicare would reimburse for. But
Chronic care management.
yeah, so it's something that you could do, but it would have to be more like you'd have to be following the hemoglobin A1Cs and medications and doing education about those things. And then you could fold in like the exercise and then nutrition stuff as well, and just to that as well.
Yeah, because the only way we're gonna survive the boomers is to have prevention for the rest of us, because boomers already have all their chronics.
Yeah.
Exactly.
And it's complicated and people are sick.
A lot of people don't even know that they're sick.
True, a lot of people don't even know they're sick.
Yeah.
If you are on the Zoom and you do not know if you are sick or not, please get a checkup. Please get a checkup. Dr. Tarrant, you unmuted.
What's
You
your
want-
problem with boomers? I'm a boomer.
Yeah,
It's not a problem.
yeah.
Our
You guys
healthcare
wouldn't be
system,
here if it wasn't for us. Get
No,
off my lawn.
your healthcare system, that's the problem, and you guys know it. It's you, none of us, we've been treated a sick care system for decades and decades and decades. And so many boomers have not taken care of themselves because they didn't know. You guys know, but not everybody does. And so that's good. That costs the system a lot, time, energy, and money. Finally got a PCP book. Yes. Yay for Tyler. Good job, Tyler. Thank you for sharing that. It is not easy in a medically underserved community. So you stick with your guns and you keep that appointment at any cost. If your boss says you have to do something, you tell them to come talk to me. And I will tell them no. Okay, are there any more questions or comments? I really appreciate everybody coming. This has been very fun.
This first seminar.
Yes.
These were
If-
really good presentations. I enjoyed this.
Thank you. I will put my email in the chat. If anybody has any questions about JBI, the things that we do here at Touro, Nevada, you are more than welcome to email me. And I just thank you very much for this chance to share with you some of what the different departments are doing and what our clinicians are doing. And we will see you soon in real life. Thank you.